So our next session is Splenohepatomegaly, how do we approach? Presenter Dr. Shah, moderator Dr. Seema Alam, panelists Dr. Priya Kishnani, Dr. Archana Kher, Dr. Manoj Ghoda.
Good afternoon, everyone. I am presenting a case splenomegaly. Usual presentation with the unusual codes.
Slow, yeah, go ahead.
At present, child is 3 years, 4 month old, a girl child. She is born of the 5-degree consanguineous marriage. Her antenatal history was uneventful. She was born of full-term normal delivery. Baby cried immediately after birth. Birth weight was 3.25 kg and Apgar was normal. Her post-natal course was also uneventful. There was no any history of neonatal cholestasis. At the first, child was actually first being evaluated at the 1.5 years of the age. At that time, child has had come with the complaint of mass in the left upper part of the abdomen and progressive upper abdominal distension since last 4 to 5 months. That mass was observed since 4 months of the age. On inquiry, mother was telling that there was some tonic posturing of the neck was there. But however, this tonic posturing was not associated with any uprolling of the eyeballs, tonic-clonic any movements, not loss of any loss of consciousness or cyanosis. These were the only 1 to 2 episodes and they were never recurred. Child was not started on any medications for the same. For the systemic evaluation, we have also asked for the jaundice that was not present. There was no history of pallor, no history of any blood transfusion, no history. There was no any history of joint pain, joint deformity, bone pain, or bone pain. There was no any history of repeated infections or bleeding from any side, just like a melena or hematemesis. There was also no any history of seizures or altered sensorium. Child has a...
Yeah, we stop here.
Yeah.
Situation now of upper abdominal distension and someone with some neurological findings. So what could you start thinking about in this setting? This is for the audience.
Left-sided, you said left-sided?
Yeah.
Left side.
Left-sided abdominal distension with convulsions, or query convulsions on tonic posturing.
Correct. Correct.
Okay.
With some neurological component.
Component,
right?
yes.
Yeah.
Okay.
Child had a global developmental delay. Developmental age was at 10 to 11 months at the 18 months of the age. So developmental quotient was around 62%. So in summary, we have a child who has a progressive upper abdominal distension, most likely because of the organomegaly and with a global delay.
So we have this child who's possibly having an organomegaly. Since they're talking of left side, so possibly, we'll see it later on, with a neurological involvement and a gross developmental delay. Would you like to, say come out with some differential diagnosis that come to your mind immediately with these 3 things in front? We can then go to the panelist after that.
Gauchers.
Would you want to go to Gauchers straight away, or would you want to go to the a broader group, and so that we can come down that group, a more method, that would be helpful in.
See, there is lipidosis, gangliosidosis. So,
which is that group which will more
very
often
broad. Can you still narrow down?
Under lysosomal storage disorders, which is this disorder, which are more likely to be here in this particular case? We can consider up to lysosomal and go ahead if you want. What do you feel, Dr. Priya? Should we go ahead with lysosomal?
Sure. Why, amongst the lysosomal, which ones would you be thinking of, in which categories?
Keeping in view the organomegaly.
Yeah. So Gaucher was one. What else? Niemann-Pick, yes. Yes.
And?
Gangliosidosis, which one? GM1. But
how much
not described any facial dysmorphism. They would come with coarse facies.
No, there's just developmental delay. A very mild one, just 6 months behind.
Yeah.
Yeah.
So now
let's go ahead.
Yeah.
So on the examination, Child was afebrile, heart rate and respiratory rate was normal. Anthropometry wise, child weight and head circumference was between the 15 to 58 percentile according to WHO. So child was well grown basically. On general examination, pallor was present. There was a left eye convergent squint was present. However, there was no any oculomotor apraxia most probably. No icterus, cyanosis, clubbing or lymphadenopathy was present. There was no any features of hemolytic or coarse facies, bleeding manifestations, bone tenderness or joint swelling, and there was no any signs of liver cell failure was present. On systemic examination wise, per abdominally, child's, as you can see in the photograph, child's abdomen was distended and umbilicus was distressed downwards. Liver was 6 cm below the right mid-clavicular line and 5 cm in the mid-axillary line. Span was 9 cm. Liver was firm, non-tender. Spleen was 14 cm below the left costal margin. There was no signs of ascites and the rest of the systemic examination, including the CNS, was normal.
So now let's just go back again. So now we've got a child with a splenohepatomegaly.
Splenohepatomegaly.
Right?
Yes, ma'am.
With strabismus.
Go to that line.
And also the third thing was you said with
Next
arching
slide,
of the back, right?
Yes.
But no real history of seizures. So with this information now.
And a convergent squint.
And a convergence, yeah.
Go to that slide where you put up everything. Yeah, next. Yeah. Without jaundice.
Is there anything else you'd like to know or ask, or do you think you can, what would you do next here?
Fundus.
Yeah.
Yeah. Fundus was normal.
Okay.
And there was no any evidence of the cherry red spot.
Okay. So what conditions are ruled out when fundus is not showing a cherry red spot? Okay.
Like?
Niemann-Pick and GM1 are almost ruled out.
Okay. Can we just rule out
Anybody volunteers for causes of cherry red spot?
Yeah. And? And what about oculomotor, what about the convergent squint? Does it give you some idea?
Some ideas, yeah.
The convergent squint, he had a left-sided, he didn't have a bilateral, but he had a unilateral left-sided convergent squint. Among the lysosomal disorders, are there any eye signs that you would be interested in? Supranuclear or something else? Vertical gaze palsy. Okay, so that's not there. It's a left side convergent squint. Okay. So we are still stuck on the lysosomal disorders. We are not going down. We're not making it a little more specific. Or are we trying to come out with 2 diagnoses or 1 or maybe 3? Dr. Priya, are you okay with lysosomal even now?
Yes, and I think we've excluded a few things through absence of coarse facies, through absence of a cherry red spot, and we've also got eye findings which are more in the direction of a convergent squint, and with arching. So I think we are narrowing where we started out from. And so what do you think you would like to do next in this particular situation? Or is there any other information that you would like?
What do you want to do next? Any investigation that you want now?
Somebody said bone marrow.
X-rays?
Bone X-rays?
Bone X-rays,
Yes.
okay.
X-ray
There
all
were no bone involvement. If he told you, John, no joint pains, no joint involvement.
You can get osteopenias and otherwise a bone marrow biopsy.
Yeah.
Bone marrow. Somebody said bone marrow and bone marrow biopsy. Okay, let's go ahead.
Next one. So we have most probably with the lysosomal storage disorder. On investigations wise, child has a mild anemia. However, which was not progressive. There was no leukopenia. Platelet count was on the lower normal range, but this was also not progressive. Anemia may be because of the nutritional microcytosis is there, and retic was normal.
Can you wait? This information of the hemoglobin being a little lower, TLC being a little lower, and then the platelets being a little lower, with the MCV of 64 and the reticulocyte count of 1.4 corrected. Does it give you some ideas? Does it really help you?
Hypersplenism.
I think it's all because of hypersplenism.
I think the low MCV is also really important to know that it looks like there's a very big nutritional component here, and it seems like this child also has iron deficiency at this particular age, from what we are seeing. And the other thing is the reticulocyte, there's not hyperproliferation or a reactive marrow in this particular setting, which could be related to the deficiency.
Deficiency.
Yeah. What's that? Yes, it's about 3 times what the hemoglobin is, right? So that's what we would expect.
So there's a mixture of possibly hypersplenism or nutritional, because you have platelets also on the lower side. What about the liver function test?
Liver function test, SGOT and SGPT was around 4 times elevated, while the rest of the liver functions, alkaline phosphatase, GGT, total protein albumin, bilirubin, and PTNR, all were in normal range.
So apart from transaminitis, we don't find anything there, only raised. Okay.
Further investigations, chest X-ray was normal. On the X-ray spine, there was only D9 hemivertebra was found. Fundus examination was no cherry rod spot was found. So on the sonography, there was a hepatosplenomegaly with the normal liver and spleen. Both echo X-ray was normal.
I think it's important to say it's a splenohepatomegaly because I think your whole differential goes in a different direction when you say it's a hepatospleno.
No hypertension and portal diameter was normal. Hemoglobin electrophoresis was normal, and which has conclusively ruled out any possibility of hematological disorder. Bone marrow biopsy was done at the time, which was reported as normal.
So the spine X-ray, just go back. So the spine X-ray shows just D9 hemivertebrae. Were you looking for something when you do an spine X-ray in this case?
Not in the spine.
So any one of the panelists would take that question about dysostosis multiplex, but then that is not a complete picture that you see there. Or sclerosis, So that is not there. Then the rest of the things are more or less fitting into whatever we found up till now. Now is the question is bone marrow reported as normal. Was there a need to do a bone marrow here? That is one question I would like to put to the audience first, and then take it to Dr. Priya. Okay, so let's have it from Dr. Priya. So what do you think?
I think it's different in, at least, I know I trained here, but in the US we wouldn't have gone straight for a bone marrow. Given this situation, you have very cheaply available biomarkers that are available, or you could go straight for white blood cell for testing from an enzymology perspective. So I would have headed in that direction given the information that we had. I don't think there's a need for a bone marrow in this setting.
Why? Because the bone marrow may not be very specific. Is that the reason?
That's correct. I mean, you're still coming back to a differential, because even if you get the presence of Gaucher cells or Gaucher-like cells, you still have not come to your diagnosis. They not necessarily
be present in one. Right. They may be present in almost all of them.
Now, if we had gone a step ahead of just a splenohepatomegaly with no neurological and a suspicion of whether you've got a hematologic versus a storage disorder, there I think is a role for a bone marrow there. But in this situation, I think we've narrowed it sufficiently that you could go straight for enzymology.
Okay. So let's go. Let's go ahead.
Madam has said, they have gone for the enzyme studies, child was gone, that leukocyte beta glucosidase activity was low. It was a 46% of the lower limit of normal. Plasma chitotriosidase was elevated, around 70 times higher than the normal. And the sphingomyelinase was done, which was a normal in range. Actually, this investigation was done already.
Before he came here to them, these investigations were done elsewhere, and he was sent here after that.
So then why was the need for a bone marrow in this?
Actually, everything was
done. Everything was done there.
So when you look at this, can you discuss, or anyone in the audience, what's the importance of these?
So the first enzyme appears to be about 46% of the normal limit. And the next one is the macrophage activating. So that's very high. Does it really give you any further information? I would take the question to Dr. Priya, if anyone else would like to take it, as to beta glucosidase being almost 46% of the lower limit of normal. How would you interpret that?
I would say it's
Normal.
yeah.
You'd say it was affected.
Yeah,
Okay.
yeah, absolutely. I
So
mean, the other,
Chitotrioxide is really very markedly elevated.
so that's
again,
suggestive
the
of macrophage.
Activation.
Activation.
But is that specific?
It's not specific, and I think that's another key point to make, that even if the chitotriosidase was normal, it does not exclude Gaucher or a macrophage-mediated disease, because you can have certain polymorphisms and certain changes which can give you a normal chitotriosidase. So if you're going for the biomarkers, then you want to go for the whole triad of the ACE, which is the angiotensin-converting enzyme, the
ACE, yeah.
chitotriosidase, as well as the TRAP, which is the acid phosphatase, the tartrate resistant. Because the chito can be normal depending on if they particularly have that. But to me, you've already made a diagnosis with your low enzyme activity in that situation.
46%. We'll go further and we can discuss.
Let's see, yes,
Yeah.
and see if this is.
So we have when child was suspected as a neuronopathic Gaucher's disease,
Yeah.
that is type 3, in view of the low beta glucosidase activity, and we have some neurological impairment, convergent
Right.
spleen with some tonic posturing.
Right.
And with this report, child was referred to our institute for the enzyme replacement therapy for the Gaucher's disease.
So can we just go back one more minute? You've got a 3-year-old who's got eye findings, but in addition to that, he's got some arching of the back.
Yeah.
So I know that we always call it as type 2 and type 3, but I think it's a continuum of disease spectrum. And I think the better way to call this is neuronopathic Gaucher
And
disease.
non-neuropathic.
Because in the strictest definition, type 3 is really restricted to eye findings. And we already know this is beyond that, at least from your clinical description of the child.
So you would call it as the type 2?
I would call it neuronopathic Gaucher because it's in between type 2 and type 3. It's a continuum of disease spectrum. So I wouldn't call it either or here. I just call it neuronopathic Gaucher disease.
The classification that we know of is a non-neuronopathic, that is type 1,
Correct.
and type 2 is the neuronopathic,
Right.
and the third one is intermediate, which is
Correct.
this.
Type 3.
Type
But
3.
now there's a further description of it being a continuum, and you have some patients who are in between type
Okay.
2 and in between type 3, which is what
So where
this
you
is.
would like to keep him there.
Right.
Okay.
Right.
So not everything is fitting into type 3,
Right.
and the patient was sent for enzyme replacement therapy. Go ahead.
However, there was some unusual, it was not going as characteristic with the Gaucher's disease. First of all, anemia and thrombocytopenia was not progressive. Second, on follow-up, hepatosplenomegaly was also not progressive. X-ray spine did not show any typical features of Gaucher's disease,
Correct.
like a
Right. So I want to
Osteopenia.
again back up one more minute. You said that the patient was sent for enzyme replacement therapy, which is an extremely expensive
Yeah.
therapy. So before you really put anyone on a therapy, you've really got to confirm a diagnosis.
They don't
So-
do that. They're
What's
doing
that?
that. That's
Okay.
definitely
and
coming forward.
Gaucher
to
cells
that.
were not observed.
Exactly.
In the
This
bone
is very
Yeah.
concerning. Yeah.
marrow. Yeah.
So with all these things, they went back to the case again with all
Right.
the, yeah.
Right.
So we have again go with the further evaluation. We have repeated the bone marrow. Again was not showing any Gaucher cells, but there was some foamy
Foamy
macrophages
macrophages
was
present.
present. This was the foamy macrophage.
I would like to ask Dr. Priya to tell the audience as to what is the difference that they are seeing in them, and what significance does this have? That these have only foamy macrophages.
So these are not typical Gaucher
Gauchers.
cells. Right, that's exactly right. So I mean, I think that working very closely with your pathologist or with the hematologist, when you have done a bone marrow, you're really committed to going to sit down with them to see what this is, because this clearly you would have had your answer since
Yeah.
the bone marrow was done. You would have had an answer right here
Yeah.
that this is
The foamy
heading in the right-
macrophages
yeah.
would give you some answers here.
right.
Go back, yeah.
Repeat beta glucosidase activity still normal but not so low. 75% of the lower limit of normal. Plasma chitotriosidase still elevated about 33 times. And the genotyping was normal, and now which has conclusively ruled out at least Gaucher's disease.
Okay. So this is the reason why before the ERT therapy, they went back again to
So the other thing is, where was this enzyme activity done, and what was the normal control that was used?
Yeah.
Because I think really when we interpret these laboratory findings, it's really critical to
I think
know
that's-
what was done and what was it controlled against. So just giving this activity, it also depends on the particular lab in which it was done. So here we have to assume when you're giving information that it's in a reputable lab or in a reliable lab.
Yes.
Okay.
Okay. So you would think that now that this shows 75%, you would keep this as normal, glucosidase activity?
So the other key thing to give in this, the take home for I think all of us here, is you don't go just with a number and an individual lab finding. You have to go with the whole child as a complete. So there are findings. It's very suggestive of a storage disorder, but now you've got foamy macrophages, you've got absence
of the glucosidase.
Of the glucosidase, and you've got actually
Squint.
no
Yeah.
the hemoglobin and the
improving. Yeah.
and so all of it is not fitting in. So jumping to an enzyme therapy at this point seems premature
And they did
or
the-
incorrect. And the genotyping is not showing you GBA gene mutation. So now let's see what.
Yeah.
Yeah.
Go ahead.
With the further course of the child, child has a progression of the neurological disease was found. There was a drooling of saliva was there, difficulty in swallowing, coughing and choking during the deglutination was there, and there was now started a regression of the milestones, mainly in the form of the motor milestones was regress. Child has now stopped cruising and standing with support at the 2.5 years of the age.
This is very obviously regression. So,
Yeah.
yes, Dr. Archana.
So anybody wants to
Yeah.
discuss other DDs? Now
Yeah.
there is frank regression. Anybody? No cherry red spot, progressive regression, and there are some corticospinal tracts are probably involved because dysphagia is also coming up as a symptom.
To begin
And
with,
motor
it's
milestones are also delayed. So there's definitely involvement of corticospinal tracts.
to begin it with, it was a splenohepatomegaly. Now it's the neurological this thing which is picking up. So and with the foamy macrophages that we saw in the bone marrow, what else would you think of apart from what you just said? And I also would chip in the squint. It is not definitely a classical squint, but a squint. Okay.
You go ahead.
Now at present, child's anemia has been corrected with the hematinics. Last hemoglobin is 11 and platelet is 3.45 lakhs. Child has a bulbar palsy. Child has been severe dysphagia, so he has been put on the nasogastric tube feeds, and
Complete
Yeah.
this.
and the child has now lost the weight, and child is now more regression of milestones. Child is now confined to the bed, and even no head holding is
Yeah.
there.
So Archana, what?
Did you repeat any other enzyme? You had shown one slide of sphingomyelinase
Yeah.
done. Have you repeated
That we will come after
That,
this.
ma'am, not
So,
sure.
yeah.
Correct.
And then the regression of the milestones with neurological involvement.
Correct.
Any other clause which we often see now? What is that storage is of?
I would keep with foamy cells with now initial, splenohepatomegaly, later on going on to be becoming more neurological, and the fact that the rest of the tests are coming to be normal. Now, I would now, bend towards NPC, Niemann-Pick
type.
C.
Correct.
C.
So commonly we were taught, if you have regression of milestones, not necessarily initially you may have, and you have splenohepatomegaly, you would think of a Niemann-Pick disease, a condition. So that is the closed DD in this
Yeah.
patient.
Absolutely.
There's a very close DD. It should have been there right in the beginning because he was showing a lot of neurological
Yeah.
signs which were in favor, foamy macrophages.
And you have 3 different types of Niemann-Pick.
I'm saying C.
Yes.
Right.
Niemann-Pick disease should always be mentioned along with the type.
Yeah.
What about an MRI at this stage? Was it never planned? Because so many neurological findings have come up.
Mm-hmm.
She was possibly at a liver center.
But even then, with so many neurological findings coming up now, did you plan
yes.
an MRI?
Did you?
No.
No, the issues at the neurological center came for a ERT, so they were just confirming the
Diagnosis.
type.
Covered.
Yeah, go ahead.
At present, this is a
yeah.
child. She is
Let's go
confined to
ahead.
the bed,
Yeah, go ahead.
undernourished. There is some there is a flexion at the wrist joint and the ankle joint. Plantar flexion is there. So suggestive of the tone disturbances or joint contractures. These are the weight charts.
Go ahead.
Showing
She's
the
not doing so well.
not showing doing so well.
Weight loss and everything not
So
doing
in
so
summary, at present we have a child who has a non-progressive pallor and splenohepatomegaly, has a global developmental delay, which is followed by the regression, mainly the motor regressions, non-paralytic squint, form cells on the bone marrow, and the mildly reduced level of the beta glucocerebrosidase activity and absence of the mutation of the GBA gene.
I would ask Dr. This is short time. We're not.
Did you repeat the enzyme?
Yeah. Again.
For that sphingomyelinous, ma'am.
Yeah.
No, we have not repeated. Sphingomyelinous, we didn't repeat it.
And was Saposin C done?
Saposin, we had keep in one of the possibilities, Saposin C and also the prosaponin.
Yes.
Process one. Both of them been kept there, but this has not been investigated on those lines. But whatever was available in India was Niemann-Pick. So keeping that as the first, yes, go ahead.
Yeah. So we have done a genotyping mutation for the NPC gene 1 mutation, which was showing the pathogenic homozygous mutation in the exon 8 with the nucleotide change in the codon 1211. Guanine replaced adenine, and which results into the amino acid change arginine with glutamine. So our final diagnosis was Niemann-Pick disease type C.
So what is the take-home message from this particular case? That I think we were very close with the lysosomal storage disorder. And when a bone marrow was done, I think we had to commit ourselves right at that point because a diagnosis could have been made if that evaluation had been done very appropriately. The thing is, the increase in the chitotriosidase is suggestive of macrophage activation, which goes along with either of them. Yeah. And you had neuronopathic findings pretty early, but there were some warning telltale signs in it. And the other part is the laboratory. I mean, because you initially had normal activity, I mean a low activity of glucocerebrosidase. It was
46%, yeah.
So even when you look at it as a percent, when you look at the range, it was below that particular range. So to me, that was an alarm signal right there that the laboratory doing it doesn't have appropriate ranges going on there, because you could have been led down the wrong path and put a child on enzyme replacement therapy inappropriately.
But there is actually one case has been reported where the same finding means beta glucosidase activity was low.
Yeah.
Chitotriosidase levels were high.
Correct.
Child was started on the enzyme replacement therapy, and there was no response.
Correct. We've seen many such cases, and that's why the key part is before enzyme replacement therapy, you have to confirm it by mutations, especially when you're committing it for enzyme replacement therapy.
So we have same take-home message that storage disorders can have overlapping clinical features.
Absolutely.
Discrepancies between the clinical features, disease course, and investigation. You should always alert for the alternative diagnosis. Mainstay of the diagnosis is always a genotype, with or without estimation of the enzyme activity. And bone marrow requires expertise for the interpretation. And confirmation of diagnosis is must, as the enzyme replacement therapy is disease specific. As enzyme is disease specific.
Right.
Yeah.
Cholesterol
storage.
Transport. Yeah. Right. Correctly.
Yeah.
Yeah. Yeah.
It's a complex cholesterol trafficking disorder.
That's why typing of Niemann-Pick disease A, B, C. When you are seeing classical liver involved,
right, that's
then
B.
It's a trafficking defect. That's very important. Not sphingomyelase levels, which are going to give the diagnosis.
Yeah. C doesn't have sphingomyelase as apps. I have one more question here for Dr. Priya. They describe NPC1 and NPC2. How do we go about with that?
I think it's a continuum even there, and so classifying it. I think the presence or absence of neurological involvement, and I think Niemann-Pick B and Niemann-Pick C are actually two completely different diseases. They've just been lumped together, but the mechanisms are completely different. So I think that's another important take-home message.
Yeah,
it really does.
We have a major problem in the country. That is with labs.
And that's, yes.
labs, and we just say, oh, they have given us a report, it's all right. So we have to actually, in India, there's a big requirement of developing labs which are actually which are validated.
You're right, sir.
Controls are not there. You see the reports which we are getting for hepatic copper are wrong. Galactosemia are wrong. Many a times we have seen. Therefore, don't bank totally on that. As clinicians, take total picture into consideration and do what is best and what is preventable and what is treatable.
Yeah.
I think at the moment that is the requirement. Lab has to be developed. There are so many disorders.
Right.
Yeah.
Yeah.
And is there any treatment?
IAP. That is the job of pediatrician.
Is there any treatment available? Not for NPC.
Actually, for Niemann-Pick C, there is the availability now of Miglustat.
Miglustat,
which is, substrate reduction
immunosugar.
therapy. Yes, but it's not a curative therapy. It can just prevent the progression.
It's a SRT, which is substrate reduction therapy.
And the Miglustat was originally developed for Gaucher disease, but can also be used for Niemann-Pick C. Niemann-Pick B, there's definitely enzyme replacement therapy in clinical trials at this point.
Thank you, ma'am. Thank you.
Thank you.